Good afternoon. Today we just have, again, the great pleasure to hold what it has come to be a wonderful event of networking scientifically and also with community outreach. This is the Midwest Rare Disease Speaker Series, and it's a network that was born from a few colleagues getting together, and now we are actually expanding throughout the Midwest. In addition of expanding throughout the Midwest, members of our networks are working with other places nationally, which are outside of the Midwest, as well as places that are in Europe or in Asia or in Turkey or in Latin America as well, to try to bring more communication in what it is for us, a duty and a passion, which is rare diseases. Today, obviously, I will have my partner here from the Mayo Clinic, Dr. Pinto Evairo, who is here with me. He will be coordinating the entire event with the presentation, then the introduction, and also the Q&A. Again, enjoy today's presentation, which I already took a pic, I have to tell you, and it looks like a great one. So thank you so much.
Good afternoon. My name is Filippo Pintivairo, and I am Associate Consultant at the Center for Individualized Medicine and the Department of Clinical Genomics here at Mayo Clinic. And I would like to welcome you all to the Midwest Rare Disease Speaker Series. This is a joint venture between the Mayo Clinic and the Mellowes Center at MCW. It is an opportunity to highlight the work being done regionally across the Midwest around rare disease. And this lecture series is designed to expand interinstitutional collaborative efforts in rare disease research in the Midwest, provide a platform to share promising research efforts and open discussion, bring together rare disease researchers and clinicians for networking and future collaboration. Today, it's my pleasure to introduce our presenter, Dr. Christen Ebens. Dr. Ebens is a pediatric blood and marrow transplant and cellular therapy physician at Minnesota Health Fairview Masonic Children's Hospital and the Pediatric Specialty Care Journey Clinic. Her research interests include hematopoietic stem cell transplantation for non-malignant disorders, including autoimmune diseases, primary immunodeficiency disorders, and Epidermolysis Bullosa, and development of adaptive immunotherapeutics. Dr. Ebens is also an assistant professor in the Department of Pediatrics and a faculty member in the Division of Blood and Marrow Transplant and Cellular Therapy at the University of Minnesota Medical School. Today's presentation is titled Building Upon a Platform of Immune Tolerance in Epidermolysis Bullosa, and the objectives of this presentation are to define the practical evolution of allogenic hematopoietic stem cell transplant in a rare disease when moving from a murine model to human patients, recognize how immune tolerance can be leveraged to support non-hematopoietic tissue transplant, and identify novel technology in future efforts in Epidermolysis Bullosa. Throughout the talk, please use the Q&A in Zoom to submit your questions. We have planned at least 10 to 15 minutes of questions and answers at the end of this session. So now, please join me in welcoming Dr. Christen Ebens.
Thank you for that introduction. I'm going to go ahead and get my screen up. So thank you for the kind introduction and the invitation. I'm always excited to meet other folks working in the areas of rare disease, and I really look forward to the discussion at the end. It sounds like quite a diverse crowd comes to these talks, and I think that diversity and interests really helps move new projects forward. And so maybe some collaborations can be established. I have no disclosures to share, and you already heard the objectives, so I'm going to jump right in here. So Epidermolysis Bullosa, aside from being challenging to say many times over, is a rare disease. It's in fact something I hadn't come across in my training until I came here to the University of Minnesota 9 years ago. So I want to briefly introduce you to the disease. There are a number of different subtypes of epidermolysis bullosa. The family of diseases are genetic and inherited, some forms with dominant inheritance, some recessive, but all are most visibly obvious as blistering skin diseases. That said, the proteins that are affected by the genetic mutations are not strictly within the skin. So we very rigorously consider all of the systemic impacts of the disease and try to focus on a combination of therapies, so both systemic and local, which are often targeted to the skin. So this depiction here on the left, you see the full thickness skin in a very simple viewpoint from the underlying dermis to the overlying epidermis. And then we zoom in here on the dermal epidermal junction. And those greater layers of skin, the epidermis and the dermis, are linked together by a number of different interlocking proteins, all the way down to anchoring fibrils composed of collagen 7 that link down in through the dermis and intercalate with collagen fibrils that we're probably more familiar from medical school, for example, if that's where your training is. But at each level, there can be mutations in the proteins that form that link. So type 7 collagen mutations lead to recessive dystrophic epidermolysis bullosa or dominant dystrophic. Mutations here in these proteins in blue, either laminin alpha 3, beta 3, or gamma 2 that combine to form this laminin protein, or type 17 collagen. Those mutations are just above the lamina lucida and lead to junctional epidermolysis bullosa. And then mutations in protein folding abnormalities up within the epidermis itself in proteins of various forms of keratin lead to EB simplex. So the location of the mutations will kind of lead to the different symptoms of disease, as well as the location on mutation analyses. So when you do a skin biopsy, if you examine the microstructure by electron microscopy, this is what a normal skin looks like, with your epidermis up here and your hemidesmosomes, these darker material here. This lamina lucida got its name by this clear appearance, and then the lamina densa, where you have the anchoring fibrils looping down into the dermal section with this thicker collagen that intercalates. So the various subtypes here, I kind of depicted their, added their incidence, are quite rare, although centers that see a lot of these patients, it seems more common. And at the university, we have a multidisciplinary EB center in which we provide kind of basic supportive care across all of the various subspecialties. And then what I'm more interested in taking part in is development of new therapies for these patients. As I mentioned, the plane of cleavage of the skin, or the weakness that leads to the blistering, is based on the location of the protein. And then some of the symptoms are really dictated by that as well. So EB simplex and junctional EB, being up above the dermal epidermal junction, tend to have less fibrotic changes, whereas dystrophic EB, being down in the level where you're getting fibroblasts activated with healing, has a lot of scar tissue formation that can ultimately lead to pseudosyndactyly, or apparent fusion of fingers and toes, although the finger and toe bones themselves and muscles are not fused, but just kind of encapsulated in this cocoon of scar tissue. So a lot of functional defects there. Other areas where there's blistering and healing, you can get stricture formations, particularly in dystrophic EB, anywhere the top end of the GI tract, so esophageal strictures, strictures around the mouth that makes it difficult to open fully to eat, and then at the lower end of the GI tract as well. There are subforms of junctional EB where the mutations are all associated with pyloric atresia, which is a little unique. But otherwise, skin and nail involvement for any of these is fairly common. and then poor dentition as well. Just as a warning, these can be a bit difficult to look at. So this is just an example of one patient with recessive dystrophic EB who at birth was noted to have ulcerations of the skin and blisters, as you see here. And these progress pretty quickly over the first couple of weeks of age. You can see areas where there's likely more friction or more affected. And it can be pretty dramatic. These patients in general need care along the lines of folks with second-degree burns. A lot of pain, a lot of itch to manage, and then really careful care of the skin to avoid infection. These are some of the manifestations, particularly with dystrophic EB. I mentioned the microstomia and the poor dentition, the pseudosyndactyly, esophageal strictures that you can see here on an esophagram. But really the most apparent manifestation is the blistering and the erosions that these kids have. There are no cures for epidermolysis bullosa in any form. There's largely symptom management available. So, individually wrapping fingers to try to maintain those web spaces and not get pseudosyndactyly formation. Many layers of dressings from an emollient layer to keep things moist, to cushion layers on joints, and then holding everything in place. As you can imagine, the healing process is really quite intense and requires a much higher caloric intake than is likely possible by mouth. So many patients require G-tubes for nutrition, not to mention the difficulty that they can have eating and swallowing with some of the stricture formation. That's kind of the big picture there. So when I came to the U, this program of allogeneic hematopoietic cell transplant, or largely bone marrow transplant, this particular patient population was already underway. But I think how it came about is quite interesting. I think many people think of hematopoietic stem cell transplant for malignant diseases and how that can potentially work, and how the conditioning, chemotherapy, or radiation can help ablate those diseases, and then you're replacing that bone marrow of the patient with normal, healthy hematopoietic stem cells. For non-malignant diseases, it's also not a stretch to consider the diseases from blood-forming cells, where you can full-on replace those stem cells and give rise to healthy cells with intact donor. So there's a number of disorders listed here. This is by no means comprehensive, but certainly disorders of white blood cells that largely affect immune competence, red blood cells with sickle cell disease being the most common, platelet disorders, which are much more rare, and then the primary immune deficiencies, again, largely coming from white blood cells. Bone marrow failure disorders are certainly treatable by stem cell transplant. And more recently, autoimmune diseases have been shown to be amenable as well, if the defect lies within the white blood cell that can be fully replaced. More interesting and a little bit more complex to truly figure out are diseases that might benefit from something called cross-correction. So I think the most frequently demonstrated would be in the mucopolysaccharidoses, Hurler syndrome being the most common. These are metabolic disorders, or diseases in which an enzyme is abnormal or missing, and there's a buildup of the product that the enzyme would be breaking down, and that buildup gets in the way of the function of components of the cell and leads to cell death and a number of downstream issues. So in theory, if you can identify an enzyme defect or enzyme that's missing, or a secreted protein, as in the case with epidermolysis bullosa, it may be amenable to cross-correction if a stem cell or a cell product in hematopoietic stem cell is able to produce that enzyme or protein and secrete it where it's necessary to offset the symptoms of disease. So with EB, is this a disease that's amenable to cross-correction? So if you see these proteins here, they're clearly outside of cells and they've associated with each other in combination to form this Velcro type structure linking from the epidermis to the dermis. And particularly junctional and dystrophic EB, these laminin proteins in collagen 17 in junctional and collagen 7 in dystrophic EB have different cell types that produce them and secrete them. So because these are defects in secreted proteins, it's plausible that they might benefit from stem cell transplant. So the proteins in junctional EB are really produced by those basal keratinocytes, whereas the proteins in dystrophic EB can be produced by keratinocytes, fibroblasts that lie down in the dermis, or by mesenchymal stromal cells that can be migratory. They can be derived from the bone marrow and moved to where they're needed in the body. And then there are also tissue-specific subtypes that are established. So a few sources there that made this seem like a potential disease type that could benefit from hematopoietic stem cell transplant. So in moving this forward, overall in humans, the objectives were to decrease the body surface area of disease. So restore some of that collagen 7, create anchoring fibrils, decrease the easy blistering and wounding, and then impact the downstream pain, infection risk. And then I didn't mention this, but one of the main causes of death, particularly in dystrophic EB, is development of lethal squamous cell carcinoma in the 3rd and 4th decades of life. And then generally overall improve the quality of life and potentially length of life as well. I discussed kind of the obvious mechanism that this might work by having a cell type that can come in and restore full-length functional type 7 collagen in the case of dystrophic EB that can associate and form those anchoring fibrils. But the process of stem cell transplant also has a lot of immunomodulatory components. So during the conditioning phase where patients getting prepared to receive the donor stem cells, there's a lot of immunosuppression or immunoablation with either chemotherapy or serotherapy with the goal of having the donor cells enter the body and not be actively rejected by the recipient's immune system. That immunoablation could certainly decrease the symptoms of EB by getting at the chronic inflammation in the skin that kind of over time contributes to the disease phenotype. Later, after transplant, it's entirely possible that donor mesenchymal stromal cells, in addition to their ability to produce type 7 collagen, have a unique propensity to modulate the immune milieu wherever they're at. So in the skin, they receive local signals and have a function where they help lead differentiation of monocytes to more of an M2 versus an M1 phenotype. So more immunosuppressive versus pro-inflammatory. So these could potentially also play this immunomodulatory role in the process. So the first step before trying this in human patients was to investigate this in an animal model. There are not a lot of animal models for EB, but there is a fairly decent phenocopy with Col7A1 deficient mice on a B6 background. So these mice were lethally irradiated and then injected with congenic B6 collagen 7 intact wild type cells from GFP mice. So they were able to track the donor cells. And the experimental categories included either unsorted bone marrow that you see in pink in the survival curve there at the bottom left, CD150 and 48 negative enriched hematopoietic stem cells, or mice that did not get stem cells or were untreated. So you can see here in the survival curves that there was a survival advantage when enriched stem cells were infused into the mice. And when we look for GFP, we see that it co-localizes with expression of collagen 7 here in the merged image. Visually, you see some improvement on the paws of the mice, with this being kind of a hemorrhagic blister here on the palm, and resolution of that post-treatment. And then looking at electron microscopy, comparing wild type mouse who has intact, it's a little hard to see here, but these are anchoring fibrils that are pointed with the arrow. They're kind of wispy below the level of the lamina densa. Untreated EB, that you don't really see any of these. It's just kind of monotonous here. But in the RDEB mice that were treated, you again get some wispy projections representing those anchoring fibrils. So with the enriched bone marrow HSC showing improved survival, decreased blister formation, and anchoring fibril production, this was moved forward to clinical trials in human patients. So this is some depictions from the first publication. Dr. Wagner and Dr. Tolar led this effort. And you can see here on immunofluorescence of collagen 7 that before transplant, there was kind of discontinuous staining in red of type 7 collagen. But after transplant on day 200 and day 360, there was a nice continuous bright staining. This is really not the best way to demonstrate improvement in Col7. It's hard to quantify. It's very more of a qualitative way to show improvement. But I think the pictures are fairly obvious with improvement from before transplant on the left to after. So the initial approach to transplant, I think, is really interesting. There are a number of non-malignant diseases. At this time, we had already transitioned from doing fully myeloablative approaches like you would do with a patient who had a malignancy or a pre-malignant condition, where you want to fully eliminate the problematic cells and replace with donor cells. In a number of diseases, that full replacement isn't necessary to achieve the full benefit. So a great example of that is sickle cell disease, where you can use a reduced intensity conditioning regimen with less toxicity and get less than 100% donor engraftment, even as low as 30% donor engraftment and red blood cell production that'll alleviate the symptoms and reduce the disease from that of sickle cell disease to sickle trait, which is quite a big difference. We didn't know, and Dr. Wagner and Dr. Tolar didn't know kind of where the bar would lie to help EB. And I think in other diseases that require cross-correction, how much of a protein or an enzyme is necessary, how much correction is needed, or what percent donor cells is necessary, and getting them to the right place to get a phenotypic improvement. So the initial attempt, knowing that this could be very well a one and done sort of effort, was to use myeloablative conditioning. So avoid the risk of graft failure or graft rejection in these patients that have overactive immune systems that could certainly actively reject donor cells, and deal with the toxicity of the regimen. So back in 2016 was the first myeloablative stem cell transplant conditioning, and this just shows the conditioning regimen. It's a busulfan cyclophosphamide-based 2-alkylator approach to conditioning, followed by stem cell transplant. And then the immune suppression on the back end to prevent graft versus host disease was a combination of cyclosporin and MMF. As I mentioned earlier on, this immune suppression could actually play a role in the disease phenotype as well. So important to note that we're doing that. So this initial report showed clinical benefit. So there was decrease in body surface area affected by erosions and blisters, but it was quite toxic, and the patients were really quite sick with a lot of mucositis and need for supportive care for extended periods of time. So the next iteration of the protocol had the same conditioning regimen, but added in third-party mesenchymal stromal cells with the idea that these should both help with engraftment of the donor cells, but also aid in calming inflammation as early as with the stem cell transplant. Pretty quickly, the next step to reduce intensity to cyclophosphamide low dose total body irradiation, reduced intensity conditioning was put into effect, again, with this single infusion of a third-party mesenchymal stromal cell. So this non-myeloablative approach was definitely less toxic. They still saw some good clinical benefit, but there was an increase in the risk of graft failure, and not clear that the third-party MSCs were providing any great benefit. So to try to investigate the mechanism of benefit, there was an attempt to track these donor cells at the skin level. And donor chimerism in skin biopsies can be really challenging. Right now, the best we can do is really kind of a whole skin biopsy, not specific to cell type, to look for donor cells. In the case of sex mismatched donors, we can combine XY fish with immunofluorescence to try to identify what cells are there and where are they potentially contributing. So you can see here on the right, the circled areas are male or donor cells. The little red dot is the Y chromosome. So you see these donor cells in a few different locations. This dotted line here is the dermal epidermal junction with purple staining type 7 collagen. And then CD45 is a pan-hematopoietic marker. And so any of the cells that are kind of this bright blue are hematopoietic, and those are identified here. And then blood vessels are marked by endothelial marker CD31 here in green. So you see really the closest cell types in association with the dermal epidermal junction are these non-hematopoietic cells, which were reasoned to likely be mesenchymal stromal cells from the donor that have homed to these areas of inflammation to aid in production of type 7 collagen and immunomodulation. In these whole thickness skin biopsies, donor contribution was pretty variable and not necessarily associated higher with better clinical phenotype, but was on the order of 10 to 30%. And so that could include both these cells that we believe are doing the bulk of response, as well as hematopoietic cells that are circulating in the vasculature. So the next step then, and this is about the time that I got involved as well, was to change the format of the conditioning entirely so that we were able to find for any given patient a related donor. So anyone in the audience in stem cell transplant will know that use of post-transplant cyclophosphamide, dosed appropriately and timed kind of at the early peak of donor T cells differentiating into those that may go on to cause graft versus host disease versus those that are there to help get the donor cells in stem cells in, help with engraftment or help fight infection, kind of differentiate themselves. So when you time this correctly, you can really obviate the risk of graft versus host disease and permit for really mismatched donors, all the way down to half matched donors, which would be either a parent or a child, or even cousins in a number of cases. So we switched up our format, stuck with the reduced intensity conditioning regimen, added post-transplant cyclophosphamide. And this allowed us then to, at the time of collecting bone marrow, also grow out mesenchymal stromal cells that are donor-derived for these patients. And we administered those in 3 doses at 60, 100, and 180 days after transplant. And then there were some adjustments to the regimen. There was quite a lot of graft failure in this particular regimen. So we increased the dose of total body irradiation a slight bit, and then we added additional doses of mesenchymal stromal cells. Clinically, when patients would get these doses, it would be quite remarkable, actually, that a number of them would have come into the infusion area with a potential active infection in a wound area and would get these cells, and without antibiotic treatment, that would heal up and a matter of days. So these donor-derived MSCs seem to be quite helpful, which is why we increased the number of infusions here. But on the whole, the outcomes from transplant were somewhat inconsistent, and it was not curative. So all the patients still had involvement of their disease. I would say that they fairly consistently had quicker wound healing and less body surface area of involvement. But stem cell transplant is quite a large undertaking for a family, and poses a lot of toxicity. So there are newer therapies that are coming on board that we've kind of shifted our attention to. In the meantime, before that, once we switched to a platform where we were able to use related donors, we leveraged that immune tolerance that's created by stem cell transplant to add skin grafting to our regimen. So epidermal skin grafting can be done in a number of ways. Historically, it's been surgical resection of small areas of skin and moving them either autologously, which wouldn't be very helpful in epidermolysis bullosa, or from deceased donors, just to provide a temporary natural dressing, essentially to help wound healing. Again, unlikely to be particularly successful in epidermolysis bullosa because the wound healing is not normal underneath the injury. For victims of severe burns, it may be helpful. But we gained access to this newer device called CelluTome that I'll talk to you about a little bit. Actually, maybe I'll jump ahead just a bit. This is an epidermal harvesting device that is placed. We use the inner thigh. It's a nice flat surface area. It's applied, and once it's applied, there's negative pressure and heat is used to separate the epidermis from the dermis. And it raises up these little epidermal plugs over about 30 minutes. And when they're matured, you can place a dressing over this and employ or deploy an internal slicing mechanism to release these plugs onto this dressing that can then function as essentially a living Band-Aid. The recipient site, because it's at the epidermal level, heals without any scarring and can be repeatedly utilized moving forward. And all of this is done in the outpatient clinic setting without any pain medications for patient or recipient, no wound prep aside from just basic cleaning. So a really non-invasive method of skin grafting. So this is what these plugs look like. This is a 5 centimeter by 5 centimeter dressing with all the plugs attached that are then applied to an open chronic wound. So when we initially started this, we had a standalone protocol for epidermal allografting for patients who had been transplanted over a year ago and had stable to improving donor chimerism to show that they would be unlikely to reject these cells. We would do 3 of these grafts at any given time, up to 3 sections spaced apart by about 12 weeks. And then we analyzed that, and I'll show you how that data looked. It was so successful that we then went back and added epidermal allografting to our BMT protocol so that it would be insurance approved upfront and not require a second ask, essentially. And at that point, we felt very comfortable with the procedure and confident that the donor chimerism at day 100 would be more than adequate to support this. And so we started offering it quite early after transplant. In addition, this epidermal allografting procedure helped support pseudosyndactyly release or hand surgery to separate the cocooned fingers. And I'll show you some of that as well. So this particular patient is on the far left at baseline, and this is actually post-transplant. So she had quite a bit of improvement in her overall condition, but she had this very chronic kind of butterfly-shaped wound on her back that had been present for years and never healed. Her donor was her sister, and so we took 3 grafts from her sister and applied them in these locations here. The markings on the bottom are just outlining where the graft is and the area of open wound that is available to heal, essentially underneath. And then we took photos and followed this forward out to a year. And you can see over that time period, by 6 weeks, about half of that area that had been covered by her sister's epidermal graft was closed. And then that closed and stayed closed all the way out to 52 weeks or a full year after this procedure. Unfortunately, you see the rest of the wound is unaffected. But there were a couple of interesting things that we noted, and the photos aren't perfectly lined up, but there seemed to be outgrowth of the graft beyond the area that was grafted. And our patients who had these grafts, some had grafts before, and they felt that these were very comfortable grafts, so they were breathable. Their sweat glands and their hair follicles and the adnexal structures in the skin kind of grew into the graft as the individual plugs, the surface around them, grew out to fill that space. So these were aesthetically, looked a little like the donor skin in some cases, but they certainly were more comfortable for the patients. The fact that these lasted out to a year was remarkable and not really expected. So the usual turnover for the epidermis and kind of lifespan of a keratinocyte is 60 to 90 days, or at most out to 3 or 4 months. So we definitely didn't expect these cells to last as long as they did, or these grafts to survive as long as they did, because of the composition. We thought we were strictly getting epidermis. This suggested to us that we were having some sort of progenitor or stem cell within the grafts, and we investigated that further to help inform our future therapy development. So this is looking just after a few years of this, we had done 35 epidermal allografts and had a median of 75% wound closure at 6 weeks, and then a median of 100% with a few not fully closed out at 1 year. To look at these areas a bit more closely, we biopsied a patient. So this is a patient who is at the time of skin biopsy, 2 years post stem cell transplant and 1 year following epidermal allografting. We biopsied his graft area and then also intact skin on his thigh. And you can see his intact skin on his thigh is post-transplant, so 16% donor, but really not particularly intact on immunofluorescence. So there was easy separation of the epidermis and dermis, so the condition of the biopsy was poor. These first 6 images here that have very little red in them are various immunofluorescent stains against type 7 collagen, staining different segments of the protein. And you can see there's possibly a little bit of staining with a couple of them, maybe 2 out of 6. These are our controls, type 4 and fibrillin. But you see here where he had his epidermal allograft, he has intact anchoring fibrils. He has collagen 7 staining with all of the different antibodies. And the skin biopsies are a total of 42% donor at that site. Again, a full year after grafting. This is an example of applying this epidermal allografting to pseudosyndactyly release. So this patient, her hands look like they're held in fists essentially, and they're not able to move from that. The fingers are surgically released, and when you remove this fibrotic scar tissue, there isn't a lot left there to close these wounds. So at this point is when we harvested epidermal allografts from her donor and placed those in those web spaces. And then you can follow forward over time to see how well that area is healing. And this is out at 15 months. I've seen her 2 years after that, and she still has separation of her fingers, which is quite remarkable. These are some videos taken here before allografting. So you see she has some separation of her thumb here and a bit there as well, which is really helpful functionally. But after a year after she had her procedure and use of the epidermal allografts to help these web spaces, she's able to trace her hands and has done quite a lot of terrific art. So really, really disease changing there. As I mentioned, we were surprised that these epidermal-based grafts persisted as long as they did. So we wanted to investigate the composition of those epidermal plugs. This is healthy skin, an epidermal plug from healthy skin, single cell RNA sequencing with a UMAP showing kind of progression from the lowest part of the skin up through to the stratum corneum, inclusion of some immune cells and melanocytes and fibroblasts as well. But you can see there's a cell population down here that expresses type 7 collagen and co-expresses keratin 15, which is a marker of kind of hair follicle stem cells that give rise to keratinocytes. We confirm those in culture with co-staining of type 7 collagen and keratin 15, and then again at the dermal epidermal junction by immunofluorescence. So this particular cell type seems to be critically important. That was all healthy donor, and looking at epidermal plugs there. This is looking at the RDEB skin. So before epidermal grafting, this is what the dermal epidermal junction looked like. The patient definitely has keratin 15, but not expressing type 7 collagen. And then this is remarkably 4 years after an epidermal allograft was placed, where you have keratin 15 and type 7 collagen here. So moving forward from those findings, when we talk to our patients who've had stem cell transplant and then this grafting, they really hone in on the grafting as the most meaningful change in their disease course. So we want to continue moving this forward, and we've been considering how we can incorporate technology to kind of make some changes in this approach. So if we revisit those key observations we had with the epidermal allografting, the fact that the graft has these discontinuous plugs and has this nice circumference for the epidermis to grow out and allows for those adnexal structures from the patient to grow into the graft. This, to us, kind of defined an optimal layout of cells if we are to do some sort of fabricated skin product. The fact that the grafts grow out beyond that original site and that they're lasting much longer than we expect, that led us to investigate this stem cell population that appears to be in the graft, the keratin 15 positive basal keratinocytes that are collagen 7 expressing. We think that cell population is going to be critical in composition of any grafts moving forward. There are a number of different labs that have created artificial skin, some just growing out, culturing out keratinocytes and putting them in an air surface interface so that they form an epidermal structure. Other folks have layered cultured fibroblasts with keratinocytes, and that seems to do better. But none of them have sort of the qualities of our epidermal allograft. And we think we can do better by making sure we're incorporating the right cell types. The technology that we would like to employ includes 3D bioprinting. So this is just an example of using a robotic system that has embedded vision with electrodes, can scan an area and get a sense of a surface, even if it isn't flat or if it's mobile, and adjust printing of bio ink to fill a wound. So this is a wound on the back of a mouse, and you can see here that wound has been filled. There's very little kind of bioluminescence coming through from the inside of the wound. So we have been working in the lab on optimizing bioink for these different types of cells for keratinocytes, MSCs, and fibroblasts. and then looking at how we can use that to apply that to patient skin, either in situ or in vivo on the skin, as was done in this last example, or by creating grafts that can then be applied. Finally, this bioprinting, in addition to skin regeneration, can certainly permit us to take gene-corrected cells as well, and make grafts for use or in vivo application, or to create disease models that can be used for investigation of other novel therapies. So certainly we envision a combination approach in skin generation for EB, and trying to figure out exactly what the right cell composition for bioprinting is. So there are a couple approaches. One would be to take an autologous approach and employ gene correction to these RDEB cells and then create grafts for the individual patient. Dr. Osborne here at the University of Minnesota has been very active in this gene therapy space with EB, using really targeted therapies based in prime editing to avoid the toxic double-stranded breaks, and really wanting to focus in on targeted changes and working towards more than individual patient level corrections, but larger regions that can apply to several patients. Alternatively, and this is an area I'm pursuing, is to borrow strategies from our solid organ transplant colleagues and use either donor bone marrow or a combination of immunosuppression to achieve immune tolerance with microchimerism induction. And that would allow us to use this existing CelluTome platform using allogeneic skin grafts or epidermal allografts after inducing microchimerism, as opposed to having the patient undergo a full bone marrow transplant. So hopefully more to come on that in the years to come. Just wanted to acknowledge all the group that works in the EB Center, the Tolar Lab, and all of the other labs we work at here at the U. And then Doug Keene and Sarah Tufa at Shriners Hospital for Children do all of our electron microscopy work, and then our funding as well. So with that, I am happy to take any questions.
Thank you very much, Dr. Ebens, for this brilliant and insightful presentation. We do have some questions. I just want to remind everyone that the question and answer in Zoom is open, so please keep sending them to us. So we have questions about BE and some questions beyond AB, sorry. The first question is, did you see any improvement other than on the skin after BMT for your EB patients?
Yeah, that's a terrific question. And we did. So one of the kind of fundamental reasons a hematopoietic stem cell transplant was undertaken for this disease is to get at those systemic disease components. So we looked at need for esophageal dilatation, so esophageal stricture formation, and found that we believe to be decreased, but there's a lot of variability in how that's approached regionally or with individual physicians. And a number of our patients would just be on a regular schedule of dilatation every 3 months, whether it was indicated or not. So as an outcome measure, it would be more looking at presence of stricture as opposed to the procedure, which is much easier to track, unfortunately. But it did seem like there was a decrease in the need for esophageal dilatation, some improvement in anemia and less need for IV iron infusion. So these patients have really chronic systemic inflammation, and as many of you know, that inhibits the absorption of iron. It's a process that's really kind of well coordinated by the body, and when you have a lot of inflammation, the ferroportin just isn't out there for the iron to get absorbed enterally, and the patients require IV iron or transfusions. So we looked both at IV iron and transfusion use, and that seemed to decrease afterwards.
So another question here. Would BMT be a good approach for other skin diseases not related to collagen 7A1? Or would it be an option for other collagenopathies which affect other organs such as the kidney and collagen 4A3, 4, and 5, for example?
Yeah, I think that's it's an interesting question. I think it could be explored in cases where the collagen is excreted, which is the majority of collagen diseases. I think the timing is really critical. So in EB, for example, with the transition over time from, wounding and healing to more wounding and scarring, there become irreversible fibrotic changes. So even if you're able to decrease the blistering and wounding, you're left with scar tissue and chronic inflammation. And I think that would be really important for some of these other disease phenotypes, specifically if you're looking at impact on renal function and what damage is reversible. So it might depend on when diagnosis is made, kind of where in the disease process that is, and then what cell types are producing that particular collagen. So in the case of junctional EB, the proteins are largely produced by keratinocytes, and we did not see benefit of transplant in our junctional EB patients. I think the reason we saw the benefit in our recessive dystrophic EB patients is because there's the ability of the MSCs to produce the type 7 collagen and have the immunomodulatory effect. If it was strictly the keratinocytes, I wouldn't expect hematopoietic stem cells to be able to replace that function. Well, thank you all for taking time over your lunch hour.
We would like to thank you
or hopefully
for
enjoying your
us.
lunch hour, right?
For sure. So as we conclude this session, I would like to encourage everyone to continue exploring these collaborations to address the remaining challenges of the rare disease space, for sure. And again, I'd like to thank you for your valuable contributions and active participation, and looking forward to seeing you all in our next seminar. Thank you very much.